Next is about the mamsavaha and medovaha srotas. Now, these are bit issue of confusion. Lots of difference of opinion do exist about it, and of course, we had a fair discussion about these issues when we discussed about the samhitas in the samhita classes. But again, a bit of maybe brush up. Mamsavaha srotas are considered to be having again from Sushruta मांसवहे द्वे तयोर्मूलं स्नायुः त्वचं रक्तवहश्च धमन्यः तत्र विद्धस्य श्वेतुः मांसशोषः शिराग्रन्थेः मरणं च. Mamsavaha srotas are considered to be two in number. Now that two in number in the sense it's about the functionality, not that they are counted as physically as two, and they are related to the snayu, the muscular tissues of the body, and they also are related to the vascular system. And when there is a injury to the mamsa vahasrotas, it results in atrophy, or the total body becomes rather underweight, and there could be nodular swellings or maybe even death. Now a bit more about the mamsa in Sushruta is the mamsadhara kala. Mamsadhara kala is just below the skin, the last deepest surface of the skin, that's the subcutaneous tissue. And the other description of the mamsadhara kala is yatha hi sarak kasteshu chidyamaneshu drishyate tata hi dhatu mamseshu chidyamaneshu drishyate snayubhischa pratichannan santatam sidrayana shleshmana besitam api kala bhagamsu tan viduhum. The kala, when it is described as the layers which are accumulated with the mamsa tissue, and they are also surrounded by the other these thicker tissues or elastic tissues, which will be making the whole body covered up. So one of the major important function of the mamsa dhatu would be to cover the whole body and give the support to the other tissues. Now with all these functions, most of these can be attributed to the adipose tissues of the body. The adipose tissue in generally it's felt that adipose tissue is a fat tissue and it's something like a waste or only to add to the body weight and so on. But adipose tissue is well known to have multiple functions, and the complexity and the critical functions are quite too many. It's not only about the maintenance of the body weight, it also has a major role in maintenance of the homeostasis. The regulation of the appetite also is one of the important factor of the function of the adipose tissue. It maintains the vascular tone. The blood vessels, they have to maintain their tone. Adipose tissue is necessary, and for the wound healing proper and support to the superficial tissue of the skin, the adipose tissue are absolutely vital. The maintenance of the energy balance in the body also is a function of the adipose tissue. Moreover, adipose tissue has a huge role in maintaining the immunity and inflammation, and it also has a important function of maintenance of the temperature of the body, and of course it also has is a location for the mammary gland and pregnancy and reproduction, so on. So adipose tissue is not simply a fat tissue, it has multiple useful functions, and most of the functions of the mamsa and the mamsa janya vyadhis, they can be attributed to the adipose tissue. Furthermore, if you go into the physical description of the mamsa in Sushruta, in case of the mamsagata vranasrava and mamsagata vrana particularly, the descriptions are very clear cut. It is related to the subcutaneous adipose tissue. The discharges in case of a mamsagata vrana is a mamsagata sarvik prakashaha sandraha shvetah pichilascha. Whereas medogata is not mentioned in Sushruta as a vranadhisthana. Instead, the snayu is mentioned as the vranadhisthana, and the snayugata snigdho ghanaha singhanaka pradima saraktascha. The snayu is somewhat related to the muscular tissues, whereas the mamsa is about the adipose tissue, and they are closely interrelated. Mamsagate shofabhivrudhi shalyamarganupasamroha pida asahishnuta choshapakaucha. A mamsagata vrana would present with huge swelling, and the tract through which the point has the wound causing the instrument has entered in may not heal easily, and it produces or easily gets separated. whereas a similar condition wound in case of patient raste in between the muscular tissue, it will be producing a similar injury, and snayugate snayujala ukshepam samrambhasya udavidita. If it is reaching to the snayu is the real muscular tissue. In such conditions, there could be tear of the muscle tissue and there could be huge swelling and pain. So the description, all the point is description of the mamsa. These are more or less related to the adipose tissue, whereas the snayu relates to the muscle. Though in the routine clinical terms or routine colloquial terms, mamsa is attributed to the muscles. So of course there is a bit of overlapping of the tissue. And the other controversial issue is very popularly medo dhatu is often translated as adipose tissue, which I do not accept easily. Of course, it's a matter of controversy, and my purpose is not to make it confusing, but the clarity from what the description will say. Of course, we had a prior discussion of that in the Samhita class again, it's the same. Whereas the medo srotas, when it is involved, it results in swedagamanam, snigdhamrita, talashojaha, sthulashokada, pipasacha. This attributes to mainly the whole homeostatic mechanism of fluid and electrolyte balance, and it's related to the renal functions. From the point of view of the functionality, the medo dhatu functions are mainly related to the fluid and electrolyte balance, and the signs like pitching edema produced after a disease, there is snigdhangrata and stulashokada, pipasa, the excess of thirst and so on. That's the exact clinical features which you see in case of impaired fluid and electrolyte balance. And the medogata vyadhis, among the medogata vyadhis, sthaulya of course is one, and the prameha, which is mainly about the involvement of the fluid and electrolyte balance, is the other issues. Now, obesity often is considered as a sthaulya, and often the obesity is attributed to the fat tissue, but actually in the real patients who are overweight, it's about the accumulation of the fluid, which is more significant than really the fat tissue. Of course, again, a bit of controversial issues, there can be a lot of confusion about that. There could be the difference of opinion, but still the other way. So we will have to make some clarity, and from that point of view, the medah sneha sweda dhratvam pushtim asnancha, the functions of medo dhatu is having sneha and sweda. Sneha is facilitating the movement, and sweda the perspiration, again related to the fluid and electrolyte constitution of the body. As far as the upadhatu are concerned, rasastanyam tasoraktam asrajakanda rasiraha namsad vasat prachah sharcha medasas snayu sambhavaha. Medas is related to the production of the snayu, the elastic tissues of the body, and from the mamsa it's about tvaka, the skin and the vasa. Anyway, so I would like to again, instead of going into a very clear-cut watertight description like what is mamsa, what is medas, instead I would be putting mamsa and medas together as the soft tissues of the body which maintain the physiological condition. Now, these soft tissues of the body, like which will be surrounding the asti, sandhi, and those tissues which help in the maintenance of the asti sandhi sanyoga, asti sandhaya, asti sanyogaha tatra upanibadhascha. These are all the madhyama marga. So that's all the important clinical point of view. Now, from the contemporary point of view, when I say about these discussions, it's not to confuse you from the other part, or it's not that I am equating the contemporary anatomy issues. In the contemporary anatomy also, exactly a similar confusion does exist in terms of the tissues and their functions. So muscle tissues, tendons, ligaments, the adipose tissues, these are all now identified as separate tissues based upon the histology. But when it comes to a question of functions, there is again a close relationship between these tissues, and hence from the clinical point of view, all these tissues are classified as connective tissues. This is a very specific term. Connective tissue is a broader term which doesn't really limit to only to the adipose tissue or the muscular tissue. Now, connective tissue is defined by dictionaries, the international dictionaries of medical terms, that's about the cancer and related dictionaries, a very popular medical dictionary. I am just copying it from the uh, dictionary, the definition of the connective tissue. The tissue that supports, protects, and gives structure to the other tissues and organs in the body, and connective tissue also stores fat, helps move nutrient and other substances between tissue and organs, and helps repair and the damaged tissue. Connective tissue is made up of cells, fibers, and a gel-like substance. Types of connective tissue include bone, cartilage, fat, and blood and lymphatic tissue. Now, major portion of this definition of the connective tissues are really the functions of the mamsa and medas together. So I would be putting the mamsa dhatu and medo dhatu as the connective tissues in together without going into the finer description, finer cleavage like which is mamsa, which is the medas. From the clinical point of view, the diseases related to the connective tissue can be attributed to the mamsa or the medas. So we will be focusing on the connective tissue disorders. Now, as far as the connective tissues are concerned, they are again classified into three categories: loose connective tissues, dense connective tissues, specialized connective tissues. Now, loose connective tissues are the adipose tissue, areolar tissue, reticular connective tissues. Dense connective tissue, reticular connective tissues are the mesothelial cells present in the different organs of the body. Dense connective tissues are tendons and ligaments. Now, these two are within that range of mamsa and medas. Then comes the specialized cartilage and bone, which is the asthidhatu. Blood and lymph also are now considered as connective tissue, which Ayurvedic point of view is now maybe included in the rasa and rakta, which we have already referred to. Now, with this, we will directly enter into this. We will make it very brief now. If more discussion about this differentiation and confusion we have had at the Samhita classes. So maybe if you are interested, you may just go back to the Samhita classes at that moment. Now we will directly get into the diseases related to the connective tissue disorders from the clinical point of view. Connective tissue disorders are again a large number of disorders which are now named or which are categorized as rheumatoid arthritis, SLE or systemic lupus erythematosus, systemic sclerosis, polymyositis, dermatomyositis, mixed connective tissue disorder, Sjogren's syndrome. Then earlier the other condition was named as reactive arthritis, but the current name for the reactive arthritis is undifferentiated connective tissue disorder, and this name was attributed or used in practice since 1980, proposed by Lera. Of course, the name undifferentiated connective tissue disorder is now most of the times is limited to academic issues, but reactive arthritis, which we write popularly in majority of our diagnosis, we usually write the reactive arthritis as the diagnosis. Technically, high technical, the other term would be undifferentiated connective tissue disorder to that kind of a condition where the exact pathology may not be clearly defined in terms of biochemical parameters. We will have some fair discussion about these issues, and we will have somewhat practical clinical discussion based upon what we see clinically. So majority of the patients whom we see are either rheumatoid arthritis or reactive arthritis. Other conditions, of course, we will have discussion of the other conditions also as such. So primarily the first of the thing which we discuss would be rheumatoid arthritis. The rheumatoid arthritis is again is a condition of exact where the etiology is not known. The exact etiology is still not known, and the majority of the evidences suggest it to be an autoimmune disorder. So it's popularly considered to be due to autoimmune pathology. But the other factors which are known, so when you do not know the exact causes, naturally there will be a lot of other theories. The other theory which is now being coming up related to the rheumatoid arthritis is it's also a genetic disorder, and a gene HLA-DR 4th cluster gene now is identified, and it is seen in 60% of the patients of rheumatoid arthritis, and hence a correlation is being established, but still it's not very confirmatory. The other known causes are infectious agents like Flu-like disorders preceding the start of arthritis is also known. These are how the infectious agent theory has been developed. Majority of the patients of rheumatoid arthritis would have an initial episode of flu-like disorder, then the whole infectious the rheumatoid pathology may be presented. Or arthritis, rheumatoid arthritis can be induced in experimental animals with the different bacteria and bacterial products like streptococci, and hence the theory of infectious agents also has been now being coming into the flow as such. Presence of bacterial products in bacterial RNA in the patient's joints. When the synovial fluid is examined in good number of patients, bacterial products are seen, and this is modifying activity of several antimicrobial agents like anti-malarial agents, minocycline, which can produce a clinical change in the outcome in the clinical presentation, and hence infectious theory also is one of the coming up theories related to the rheumatoid arthritis. As I told earlier, when the exact etiology is not known, you will have many theories coming up, and these are the theories and how they are supported. Hormonal factors also are the other theory. As we see that the clinical symptoms of rheumatoid arthritis get reduced during pregnancy or the patients who are on contraceptive therapy, and hence some relationship with the hormones also is now suspected. Then lifestyle and occupational disorders, also occupational factors. As per the current data, red meat intake, vitamin deficiency, excess of coffee consumption, high salt intake are statistically related to the rheumatoid pathology, and hence there is some theory about it also. Immunological factors like T cells are assumed to play a pivotal role in the inflammation initiation of the rheumatoid arthritis, and many of these immunological factors now also are used as the means of confirming the rheumatoid arthritis. CD4 cells and the B cells also are identified with their specific antibodies, so, and which secrete cytokines. The role of the cytokines, the mediator of inflammation, in case of rheumatoid arthritis is now well known, and it has been now established. So maybe the same thing like in case of rheumatoid arthritis, the other the total somatic, to summarize the factors which are now established are the genetic factors, cigarette smoking, pollution, periodontal diseases. These are all the other theories which are unhealthy diet. Environmental factors are seen. But one interesting issue from the current literature, if you look at the recent literatures related to the rheumatoid arthritis, now this fact hasn't come yet into the textbooks, but if you read to the recent literatures, the pathology related to the gut colon or lesions of the colon or abnormalities of the colonic functions and the clinical presentation of rheumatoid arthritis. Of course, that gut-brain axis has become now one of the new maybe innovations in the medical term. Gut being responsible for many diseases. Initially it was limited to neurological conditions, or now many other diseases related to the condition of the gut or condition of the colon is now coming up into the literature. Lots of research is going on, and the relationship between the colon condition, gut condition and the rheumatoid arthritis now is becoming established, and lots of researches are going on. Relationship between the organisms present in the colon and their status, relation and with the clinical presentation of the rheumatoid arthritis is also now becoming established, and these are the real theories which establish the Ayurvedic principle of Vata having the origin in the Pakvashaya, and the theory of, or maybe the practical utility of administering the Basti in the treatment of many Vata Vyadhis, including that of neurological conditions or arthritis-like conditions and so on. Maybe one or the other day may be proved. So, from the contemporary point of view also. So, till then, we have to keep the issue alive, that administration of the Basti in these treatment conditions we have to prove, demonstrate it to the people, and of course it is already proved, like it is so shown The a theoretical description may be possible in due course of time from that theory of gut and the relationship of the different diseases, including rheumatoid arthritis. Those who are interested, they may go through these literatures. I have just put in the important, a few very established researches where a large number of data is studied and a well derived conclusions are drawn. Now, such articles I have just put in. There are plenty of now articles coming up in the research area, but those who are interested, they may go through these reference articles. So, some of these reference articles I have quoted, which I have found quite interesting from the point of view of the establishing the relationship between the gut condition and the rheumatoid arthritis pathology. So that's about one of the new areas, but this theory or these facts are not yet included in the textbooks as such. Now, as far as the other pathological observations which are now seen about the rheumatoid arthritis is the CD4 T cells, mononuclear phagocytes, fibroblasts, osteoclasts and neutrophils. They are now known to produce a major role in the pathophysiology of rheumatoid arthritis. So, in the whole course of rheumatoid arthritis, the inflammatory mediators, the whole immunological and inflammatory mediators have a role, and hence it is considered as a primarily autoimmune disorder. And the abnormal production of cytokines, chemokines, and other inflammatory mediators has been demonstrated, and now lots of such inflammatory mediators are now identified. Recently, you will get lots of research articles about this, and utility of these mediators of inflammation in the diagnosis also is coming up. And those which are now recent, earlier it was, see, in our investigations, usually we go for a rheumatoid arthritis factor, RA factor. That RA factor is not a single entity. That's all the point. The whole point of referring to this issue is that when we say RA factor, it's not a single molecule. A large number of molecules were earlier identified as RA factor, and the patients may be having multiple variations, and hence the seropositivity or the clinical possibility of making a diagnosis of rheumatoid arthritis only based upon the RA factor, it had a very low specificity. The low specificity is just around 60%. So only 60% of the patients can be having confirmed with rheumatoid arthritis when you do the RA factor study. Whereas the other 40% may have many other immunogens or mediators of inflammation as the cause for the rheumatoid phenomena or rheumatoid arthritis, and their identification is not done with the routine RA factor investigation. Now, those other these antibodies or antigens, both categories, antigens as well as antibodies, they are now being identified and they are named, and the specific tests also are being deployed, but they are not yet coming into the practical routine clinical field. Among those investigations are maybe the identified antigens which are now coming up rather in a due course of time. Yet in our setup, we have not come to that level where these antibodies are identified, but maybe in due course of time you may have some investigational means where these antibodies as well as antigens can be identified, and they are what I say as the ones which are in the pipeline are tumor necrosis factor or TNF alpha, interleukin 1, 6 or 8, IL 1, 6, 8, and transforming growth factor beta, TGF beta, fibroblast growth factor, FGF, platelet derived growth factors. These are the now going on a high level of trial, and maybe in a short time they may become, of course some of them already have been established as standard protocols for the confirmation of the diagnosis of rheumatoid arthritis in global situation, but in our Indian and routine clinical situation it hasn't yet come. But maybe in a few years we may have these as the routine investigation factors as such. Now, as far as the incidence of rheumatoid arthritis is concerned, the rheumatoid arthritis is known to have in the same families. So, first degree relatives of individuals with rheumatoid arthritis are having a 2 to 3 fold higher risk for the disease, and Disease concordance in monozygotic twins is approximately 15 to 20%, suggesting that the genetic factors have a role, but the exact role, whether it is really the genetic factor or the environmental factor which is responsible, is cannot be confirmed. See, if it is a genetic factor, monozygotic twins should have a high percentage of coexistence of the disease, and that's only 15 to 20%. But familial risk factor is around 2 to 3 folds. So that means environmental factors may have a greater role than really the genetic factor. This is how the discussion is going on. But anyway, that's about the maybe incidences as such. Now, as far as the present situation is concerned, globally, all over the world, in 2020, around 17.6 million, that's 19.5% of the age between 15.8 to 20.3 people had rheumatoid arthritis worldwide. That's a very serious issue. The incidence is quite high as such, and that's 95% uncertainty interval. The possibility of having rheumatoid arthritis in between 15.8 to 20.3 age group has a high risk possibility, and the distribution of rheumatoid arthritis also is not uniform. In the global condition, India comes under that area, that dark colored area, where the incidence of rheumatoid arthritis is considered to be quite high, whereas in the other countries it may be slightly lesser. And as far as the prediction, statistical prediction, the incidence of the rheumatoid arthritis is going to increase. By 2020, it already has reached to a level where it has reached 17.6 million. But it is believed that it will continue to increase further, and by 2050 it will cross 30 million all over the world, and hence rheumatoid arthritis would be a very serious pathology. As far as the clinical course of rheumatoid arthritis are concerned, there are many methods of identifying or assessing the course of the disease, and that again makes it more confusing. If you read different textbooks, the description of these phases or stages are a bit overlapping, confusing as such. But as far as the standard protocol, I am just selecting the most popular protocols of making this. The phase 1 to phase 5 method, where the phase 1 is where there is a pathological identification, would be by interaction between genetic and environmental risk factors of rheumatoid arthritis, where the patient may not have any clinical symptoms, but many times may be identified by, if at all you go for thorough investigation of the genetic as well as these factors, antibody factors, it may be identified. So practically that phase 1 is not much use in our clinical condition. Then phase 2 is where the patient would have autoantibodies like anti-CCP or rheumatoid factors may be possible, may be presented, but still the patient may not have the clinical presentation. So phase 2 are such conditions where the patient may be asymptomatic, but the RA factor or maybe anti-CCP antibodies may be present in the serum if they are investigated. Whereas in phase 1, the antibodies are not formed, but if you go for the genetic trial, genetic examination, that HLA gene may be identified. Phase 3 is the condition where the patient would have the clinical presentation of arthritis, development of arthralgia, joint stiffness without clinical evidence of the arthritis. And majority of the patients whom we see would be under this phase 3, phase 4 or phase 5. And the patient would have, phase 4 is when the patient would have development of arthritis and in 1 or 2 joints, and maybe and in due course of time it may spread to the whole area could be involved, and that's where you have also called as a palindromic rheumatism. The classical clinical presentation of the rheumatoid arthritis may not be seen, they may be related to 1 or 2 joints initially. Phase 5 is established rheumatoid arthritis, where you will have all the clinical norms. But important is, you may not see that kind of a phase-wise progress in all patients. Many of the patients may have different sorts of the clinical presentation. Some may have very dormant course for years together without really a pronounced clinical presentation. Some may have very rapid onset and severe deformity at the beginning itself. And hence, the other way of making the diagnosis of a clinically presented rheumatoid arthritis. Now, the initial, whatever that phase we have discussed, it also related to the preclinical condition. So, from the clinical presented conditions, it's again categorized into 4 stages. The early stage, first stage, where there is a vague, inconsistent pain and it's difficult to diagnose. Patients and good number of patients would have vague pain which may not have the classical clinical presentation of the rheumatoid pathology. But when you are going for investigation, or it may be in due course of time that the patient may develop the clinical signs of rheumatoid arthritis. Second stage is when the antibodies are formed, symptoms still may remain atypical. The typical clinical symptoms of symmetrical joint involvement may not be still seen. Third stage is where there is a clinical identifiable stage where you have that the minor and major criteria of the diagnosis of rheumatoid arthritis established clinically. Fourth stage is when the patient may have fused joints and other systemic complications. That is the fourth stage. The classical clinical symptoms of rheumatoid arthritis are mainly the stiffness of the joint. The stiffness of the joint is classically more in the morning and it will be persisting for almost an hour or so, more than even 1 hour. And the involvement would be classically symmetrical, multiple involvement, and usually smaller joints are involved and then the bigger joints are involved. But this kind of a clinical presentation need not be a must. There could be a large number of patients of rheumatoid arthritis may present with the variable clinical symptoms where the patients may not have a symmetrical involvement, asymmetrical and lesser number of joints, 1 or 2 joints, even major joints involved in the beginning can be seen, but majority would have that symmetrical polyarthritis presentation, that's a symmetrical multiple joint involvement with the stiffness, tenderness over the area, pain on motion, movement are the other criteria are making the diagnosis. Swelling around the joints. Now, rheumatoid arthritis would also have the stages of initial involvement of the perisynovial area, then the synovial membrane. During these stages, there could be the swelling around the joint. But later, the perisynovial and synovial involvement results in fibrotic changes, which results in the deformity of the joint. The joint may become having deformity, or there could be limited movements. Motions of the joints may be limited. Restriction of the movements of the joint would be the other feature, which is usually suggestive of a involvement or this fibrotic development, changes of the inflammatory pathology into the fibrotic stages as such. Then extraarticular manifestations of the rheumatoid arthritis. It may be presented in other organs of the body like the lungs, where there could be interstitial lung disorder. Involvement of the kidneys also can occur. Skin also may be involved. Rheumatoid nodules also, there could be subcutaneous deposition of some fibrinous substances also could be presented as such. In addition to these, other musculoskeletal presentations may be followed as tenosynovitis, where there could be inflammation of the tendon as the presentation, or the tendon rupture also may occur, presenting with the usually the digit extensor tendons of the wrist are involved. There could be sudden swelling around the wrist joint and the patient may have acute pain also. Or periarticular osteoporosis, where the this is a very characteristic feature. The bones become weaker, softer around the joint, and hence the bones become deformed in shape, producing the typical deformity. Generalized osteoporosis also can occur throughout the body, either due to the corticosteroid therapy or due to the reduced movement. Carpal tunnel syndrome, where the nerves may be compressed, also could be a presentation of rheumatoid arthritis. So, rheumatoid arthritis may present with the variable clinical symptoms, and hence, to make the diagnosis of rheumatoid arthritis, there are some major criteria and minor criteria which are mentioned. The criteria are making the diagnosis are clinical criteria for morning stiffness for more than 1 hour, arthritis of 3 or more joints for persisting for more than 6 weeks, arthritis of the hand joints, symmetric arthritis for more than 6 weeks, rheumatoid nodules, serum rheumatoid factor positive, radiographic changes typical of rheumatoid arthritis. These are considered as the criteria of making the diagnosis. Among them, the stiffness of the joint, multiple joints involved, and symmetrical joint involvement are considered as the major criteria to make the diagnosis. The typical deformity of the rheumatoid arthritis is again very classical. Now, these deformities are named with the different names: Buchanan deformity, swan neck-like deformity, or these are the different names. Of course, the differences are very negligible. Characteristically, it will result in the flexion of the proximal phalangeal joint and extension of the distal phalangeal joint, and based upon that deformity, the shape, ultimate result as such, is named either as a swan neck deformity or may be considered as buttonniere deformity as such. Of course, these names have not much of a significance. But typically, the deformities could be of 4 types as such, and they could be: the finger is flexible with complete range of motion, but there could be a deformity when the patient is keeping in rest. Type 2 is when the finger is flexible with restricted motion with according to knuckles position. It may be in the same axis as that of normal. But later on, type 3 is the finger is stiff with the normal joint articular surfaces, but there is a marked stiffness and the shape is altered. See, that shape is characteristic. Type 4 is the finger is stiff with the dissection of the proximal interphalangeal joint articular surfaces where the movement could be restricted. So, any of these types could be seen with these deformities. Rheumatoid nodules are subcutaneous deposition of the harder fibrous tissue which can occur around either the major joints or the minor joints, and when they are presented, that suggests about a chronic and more severe rheumatoid pathology, and clinical diagnosis can be easily confirmed about it. The rheumatoid arthritis also can present with the other clinical presentation like vasculitis. Rheumatoid vasculitis may be usually at the extremities of different degrees. It may be seen as a simple vascular patches or significant color changes, or in certain severe conditions even it may present with the necrosis like changes. These gangrenous changes also can occur, but these presentations are comparatively rare. Now, to identify these rheumatoid arthritis and from the clinical point of view assess the course of the disease, there are, again, if you look at the literature, you will find large number of such classification criteria of making the diagnosis or scoring the rheumatoid pathology to assess the severity. And to go into all that again bit confusing, there is overlapping. I have picked up a few which are quite practical, important from the clinical point of view. Among them, the 2010 rheumatoid arthritis classification criteria is one of that, which is quite popular and comparatively easy to make out from the clinical diagnosis point of view. And it will be depending upon the number of joints which are involved and the type of the joints which are involved, the first criteria. If it is a medium or large joints involved, the score is lesser. If it is 4 to 10 small joints are involved, the score given would be 3. And if there are more than 10 joints involved, the score given is 5. In between you have the 1 to 3 small joints, score is 2. 2 to 10 medium or large joints is a 1 as such. And it's only the one large joint involved. It may not be rheumatoid arthritis, it could be the other conditions related to the joint pain. A patient presenting with the joint pain, this is how you have the scoring point as it. Or the serological test will be if there is neither rheumatoid factor or the anti-nuclear ACCPA positive, both are negative, score would be 0. And one is low positive and the other is maybe this way or the other way, score is 2. If the high positive, at least in one test, then the score is 3. Duration of synovitis, if it is less than 6 weeks, it's 0. More than 6 weeks, longer. So usually the clinical diagnosis of rheumatoid arthritis starts after 6 weeks of the clinical presentation. Acute phase reactants like CRP or ESR, if it is abnormal, then again the score is 1. So that's one criteria. The other criteria, Euler criteria, which is also quite popular, is a swollen these peripheral joints, particularly hand joints, if it is present or absent, with that the relative weightage is given, and this also is another issue. Of course, not very popular, but still it's many of the research articles will present with this scoring system, where you will have the proximal interphalangeal joints, or maybe middle capsular joints as of the hand involved, wrist joint involved, hand tenderness, even the acute phase response of low level or high level as a serological positivity, you have a scoring system. The grading of the disease activity also has many grading systems, and among those disease activity grading system, DAS-CSR formula is one more formula which is again quite popular, and many of the research articles would be having this formula used as such. And the DS is calculated according to a formula composed of the number of tender joints involved and a patient's global assessment disease criteria activity, as the patient is like what the patient would feel, and the other way visual analog scale of the pain, which is commonly used, and ESR level, and C reactive protein also could be considered as the criteria, and the score is calculated as DAS 28, the 0.56 for the tenderness, and 0.28 for the constant factor for the swollen joints, 0.7 is this constant factor for the ESR, and the other this patient's assessment is the other way. If this score is less than 2.6, it is considered to be patient is showing improvement. If the score is 2.6 to 3.2, the low disease activity, 3.2 to 5.1 is a high disease activity. This is one more method of scoring. Many of the research articles would have this kind of a scoring system to assess that. Anyway, that's about the other way as such. From the clinical point of view, when and this assessment would be quite important to predict the outcome. The patients who have these factors, like a high scoring of this scoring literature, or if the patient has a genotype that genetic abnormality is identified, high serum antibodies as such, if there is extraarticular manifestation, larger number of joints involved, the prognosis will be poor. Rheumatoid arthritis occurring at a younger age of less than 30, female sex, patients who have systemic symptoms, sudden onset and progressive course, these are favorable signs as such. Extraarticular manifestations of rheumatoid arthritis also can occur in different organs. It could be like interstitial lung disorders. Kaplan syndrome is where the lung expansibility is reduced and the lungs become inelastic. Cardiac pathology like accelerated atherosclerotic changes may occur much rapidly. Pericarditis, skin changes like vasculitis, nodules, nervous system like cervical myelopathy could also be the other presentation. Scleritis of the eyes or Felty syndrome, amyloidosis, of course we will discuss about that later. In general, the important investigations which are used for confirmation of the rheumatoid arthritis are ESR, CRP, blood cell count, rheumatoid factor SA, ACCP or antinuclear antibodies, also ANA as well as ACCP, anticyclic citrullinated peptide or ACCP. Now these days ACCP is given more importance than the RA. Biopsy of the synovial membrane also could be done as the investigation of choice in specific cases. Imaging in case of rheumatoid arthritis, diagnosis of rheumatoid arthritis with the imaging. Of course, radiological evidences of rheumatoid arthritis are having a lesser role. Most of the rheumatoid arthritis is a clinical diagnosis. Even the biochemical investigations have a low specificity of around 65%. Radiological investigations also have a low specificity, and the course of the symptoms could be varying. Among those investigations, radiological investigations, ultrasonography or Doppler study can be somewhat having more accuracy, and if at all joint biopsy, synovial biopsy is suggested, then the biopsy has to be done under USG guidance. So USG has a role to play to make the diagnosis in sophisticated centers. Of course, we may not really require that biopsy to make the diagnosis in majority of the patients, but if at all you are intending to have that kind of a rigid academic diagnosis, biopsy may have to be done, and for biopsy, ultrasonography guidance is necessary to introduce the needle. Doppler study also may show hyperemic blood flow in the tendon area such of inflammation. Radiological X-ray has a minimal role, and the radiological findings could be of different variety lesions, different stages of the lesions, and we usually radiologically classify these images as the changes as the initial changes where there will be soft tissue swelling. The bones may not be showing abnormality. The soft tissues around the joint may be swollen, particularly in the smaller joints like the phalangeal joints. Then in the next course, the next stage, there will be osteopenia. The bones would become osteoporotic at the level of the joints, just juxta-articular, very close to the joint surface. The bones may become somewhat osteopenic or osteoporous like features may be seen. The density of the calcium would be lesser. Then there could be erosions of the bones, even including that of the carpal bones. Carpal joint bones may show the erosions, or the carpal joints may become ankylosed, and there could be the gap between the two bones may be reduced, and it looks like all the carpal bones are formed into a mass, or maybe in the very severe cases there could be collapse of the carpal bone. So X-ray radiological grading of rheumatoid arthritis would be based upon these findings, starting from the soft tissue edema to the stage of the collapse of the carpal bone. MRI scan also is considered to be quite sensitive, but practically we may not go for this. But from the academic point of view, MRI gives a reproducible image which can help in predicting the prognosis as well as the course of the disease. And the stages are again the same. Erosion in the bones could be identified. Osteitis, where the bones are inflamed. Synovitis, the shape between the gap between the synovial joint is inflamed or increased due to presence of the fluid around the area, and the presence of the fluid shadow in the joint is seen. Or there could be tendon inflammation also, and ultimately the joint space narrowing. So that is the advanced stage. So in the middle stage, the joint space would be increased during the synovitis stage, but in the late stage, the joint space becomes narrowed, and there could be ankylosis, fusion of the joints, which can be made out with the MRI scan also, could be the radiological criteria to make the diagnosis. Extra-articular manifestations of the rheumatoid arthritis mainly in the lungs, the interstitial lung disorders and the Kaplan syndrome, where the lung becomes somewhat a uniform brown glass-like and it's inexpansible. That can be seen either in the CT image or plain X-ray images of the X-rays. That also can be one of the diagnostic tool in case of the rheumatoid arthritis to confirm extra-articular manifestations. Then comes the treatment. We will discuss about the treatment protocol in the next session. So we will wind up today and we will continue in the next session. If there are any questions, right, there are no questions, we will wind up. Sorry.